So today we are glad to have one of our own faculty here from the Pediatric Endocrinology Division present to us, Dr. Prasanthi Gandham. She is an assistant professor in the Department of Pediatrics Division of Endocrinology. She has presented here before. She did her undergraduate studies at University of Dayton, and then went to medical school at Cincinnati, and did her pediatric residency here, and subsequently did fellowship in pediatric endocrinology at Virginia Commonwealth University. And fortunately for all of us, she's back here as an assistant professor since I think 2019. She has been very successful, presented many presentations both locally and nationally. So today she's going to talk about growth hormone deficiency transitioning from adolescence to adulthood, which is very relevant to all of us, both pediatric and adult. So thank you.
Thank you. Thank you, Dr. Moshe. All right, well, without further ado, we'll get started. So the objectives for our talk today are to review the metabolic effects of growth hormone, to discuss retesting of growth hormone secretion in the transition period, why do we retest, whom do we retest, and how do we retest, and to review management of growth hormone deficiency in the transition period. But really, the reason I chose this topic is because when I was a young attending my first year of practice, I realized very quickly that while I had started many children on growth hormone and treated them for 3 years throughout fellowship, I had stopped no growth hormone. I had transitioned no children with growth hormone deficiency or a diagnosis of childhood onset growth hormone deficiency to adult endocrinology. So I realized it was a gap in my knowledge and that it might be a gap in the knowledge of many of our other learners. So thought it might be a good topic to discuss today. It's always fun to take a look back and learn a little bit about where we started in medicine. And so we're going to take a look back at the history of growth hormone therapy. So in the mid-1940s, that was the first time that efforts to isolate pituitary growth hormone actually began. As is always the case in medicine, we started with animals. And so in 1944, they were able to isolate bovine growth hormone and then eventually porcine growth hormone. But something that I learned is that the effect of growth hormone activity is species specific. And so this had absolutely no significant biochemical or metabolic effects for humans, but it was our first step towards being able to isolate growth hormone in humans. And we finally were able to accomplish that in 1956 when growth hormone was isolated from the human pituitary gland. This was done by Lee and Papkoff at UC Berkeley and also by Rabin in Massachusetts. The biochemical structure, however, was not elucidated until about 1972. In 1958, Rabin published the results of the first trial to show the effects of human growth hormone on growth. And then in 1960, the National Pituitary Association was formed. And this was an association that really was overseeing and supervising pretty much all of the growth hormone treatment that was occurring in the US between the mid-1960s to the mid-1980s, totaling about 7,700 children in the United States at that time. In 1981, recombinant growth hormone was developed for the first time, and this was done by Genentech. And then in 1985, the FDA actually received some reports of 4 young adults who had been treated with growth hormone in the 1960s, human growth hormone, who ended up developing prion-mediated diseases. And so subsequently, in April of that year, distribution of pituitary growth hormone was suspended. But then fortunately, several months later, the FDA did approve the use of recombinant growth hormone for the treatment of growth hormone deficiency in children. And then in 1989, the first double-blinded randomized control trial that assessed growth hormone treatment in adults as opposed to in children was published. So early research in growth hormone deficiency really was focusing mainly on its implications on linear growth in the pediatric population. But eventually, over time, we developed a better understanding of kind of the really complex role that growth hormone plays outside of just its roles in growth. And so then there started to be new questions about, is there an adult growth hormone deficiency syndrome? And what are some of the other roles that growth hormone plays? And now we know that it has roles in impacting body composition. Growth hormone deficiency can cause metabolic derangements in adults. It can have psychosocial and neurocognitive implications. And so it became pretty clear that maybe we had to have a new approach and a new paradigm would need to be created as far as the treatment of growth hormone deficiency lifelong, as opposed to just in the pediatric period. So let's talk a little bit about physiologic growth, because understanding that is really going to help us to better understand pathology. So we know that linear growth and physical maturation are dynamic processes, and they're really an expression of a child's overall health. One of the most common ways that pediatricians are going to assess or follow a child's growth is through the use of traditional growth charts. The CDC's traditional growth charts were initially created using cross-sectional data from just a large cohort of children at various ages. But the population of children that they obtained this data from was quite homogeneous, and it really encompassed Caucasian, formula-fed children in Southwest Ohio in the 1970s. So just a very specific population that maybe we recognized over time wasn't necessarily generalizable to all children. So in 2000, the CDC actually revised their growth charts, and they utilized data from the NHANES database to be more widely representative of the American population. And in 2010, the CDC actually started recommending that the World Health Organization's growth charts be used for children to assess growth from ages 0 to 2, after which they recommended transitioning to the CDC growth charts thereafter. We know that growth itself involves a very complex interplay between genetic factors, environmental factors. We know that sex and ethnicity can impact how we grow. So for instance, we see differences in the female and male skeletons intrauterine and from birth, and these differences oftentimes will persist throughout childhood. The female skeleton is typically 4 to 6 weeks more mature at birth, but they have initially a slower growth velocity compared to male infants. At about 7 months of age, the skeletal maturity is quite equivalent, but then girls are going to mature more quickly. We know that females enter puberty about 2 years earlier than boys, and they have their pubertal growth spurt at an earlier stage of puberty compared to boys. One of the ways that we can get a sense of what a child's genetic potential is from a growth perspective is by using a midparental height calculation. And we'll talk a little bit about how we actually do that calculation moving forward. But we also know that height is polygenic. And so, like all things in medicine, using this calculation is not going to give us an exact idea of where a child should end up when their growth is complete, though it does give us a general idea of where they should be. Again, because height is polygenic, if you do have two parents who have very disparate heights, then we also know that the midparental height target is not going to be as accurate and reflect the expected growth for an individual child, as compared to a child whose parents have relatively similar average heights. Another way that we can assess growth is by using bone age radiographs to obtain a predicted adult height, which again, not an exact way of assessing growth, but all of these pieces of information give us a general idea of how tall do we expect a child should be, how tall do we expect a child is going to be, and are those congruent or are they disparate? Okay, so midparental height calculation. We do that by taking for boys the mother's height, adding 13 centimeters, adding the father's height and dividing by 2. For girls, you take the father's height, subtract 13 centimeters, add the mother's height and divide by 2. And that 13 centimeters essentially just came because that is the distance between the 50th percentile for height in adult men and adult women. So that's where that number came from. And this is how we calculate a midparental height target. We do it all the time in pediatric endocrine offices. If you add about 8.5 centimeters to the calculated midparental height, then you're going to approximate the target midparental height range of the 3rd to the 97th percentile for a given child. So it gives parents an idea of this is the target height, but this is really the range at which it would be appropriate for your child to end up when their growth is done. Again, it's not an exact measurement. Okay, so let's talk a little bit about the metabolic effects of growth hormone. So we know that growth hormone plays an important role in bone metabolism. Specifically, it plays a role in bone mass accrual. It does this through a variety of different mechanisms. We know that both growth hormone and IGF-1 receptors are expressed in bone. Growth hormone is going to stimulate osteoblasts and prechondrocyte maturation, differentiation, and proliferation. Meanwhile, IGF-1 reduces osteoblast apoptosis. We also know that in order to maintain a stable bone mass, we have to maintain a remodeling cycle, and that growth hormone plays a role in maintenance of this remodeling cycle. Growth hormone and IGF-1 also exert effects on osteoclasts in order to do this. So IGF-1 acts to upregulate osteoclast proliferation and activation via rank ligand, and growth hormone stimulates OPG synthesis, which mitigates osteoclast activity. So during a physiologic remodeling cycle, typically bone formation is going to exceed bone resorption, but in the setting of growth hormone deficiency, there's a decrease in the bone turnover rate. So you have a lack of balance in the rate of bone formation versus bone resorption, and therefore you can have diminished bone mineral density. What's interesting, and this is something again that I didn't know, is that growth hormone replacement actually has a biphasic effect in terms of its impact on bone. The initial phase is actually characterized by increase in bone resorption. This lasts for about 6 months, and you can actually see on bone mineral density if it's measured, though we don't routinely do that, at least in the pediatric population, that you can actually have a measurable decline in bone density. However, after about 1 to 2 years of treatment, you do see bone formation predominating and an overall increase in bone mass in children who are treated with growth hormone. There it is. Okay. So overall, the net effect of growth hormone and IGF on bone is to increase bone deposition. But again, in the setting of growth hormone therapy, we sometimes see a transient increase in resorption in the first 6 months of therapy with an overall end result with prolonged treatment of increase in bone mass. Okay, and this is just to show, obviously, it's a very complex interplay between growth hormone, parathyroid hormone, cortisol, estrogen, all of different hormones in terms of impacts on bone. Okay, so how does this correlate clinically? That's always the question that we want to ask ultimately. So in adults, we see that there can be significantly lower BMD Z-scores versus healthy gender and age-matched individuals. Holmes et al. In 1994, they did a study and it showed decreased bone mineral density in the lumbar spine and forearm, but not in the femoral neck, in patients with BMD Z-scores that were less than -2. No, I'm sorry, but not in the femoral neck. We also see a significant positive correlation between age and Z-score. So what's interesting is that the proportion of patients with PMDC scores that are less than -2 decreased in older patients compared to younger patients, which they defined as people younger than 30 years old. So essentially, I think what all of this means is that the age of onset at growth hormone deficiency is probably a more important predictor of your bone mineral density than the duration of the deficiency. And that we know that's likely because of the role that growth hormone plays in terms of accruing your peak bone mass, right? We do see in adults that there can be a 2 to 3-fold increase in fracture risk, but bone mineral density is not necessarily an adequate predictor in and of itself. In children, data is conflicting and it's difficult to interpret, and I think that's probably because there's a lack of true volumetric data. We know that DEXAs actually provide aerial measurements of bone. Obviously, if you have a child that has growth hormone deficiency, they have short stature, and so if you're not appropriately height adjusting, then you might not be having accurate reflections of what their true bone density is. And so we just really need better data to be able to get a sense of what the true impact is. And of course, bone mass accrual, while growth hormone plays a role, there's a number of other factors that play a role as well. And so if you have a child who has isolated growth hormone deficiency versus a child who has maybe multiple pituitary hormone deficiencies, including hypogonadism, it just can be very difficult to kind of tease out what's the impact of growth hormone deficiency alone on bone densities. There are some studies that have been done using quantitative CT, which is a volumetric measurement of bone density, and they've shown some decrease in bone density at the lumbar spine. However, there was another study that was done with DEXA and volumetric assessment, and it showed essentially no difference in bone mineral density at the lumbar spine or femoral neck, but cohorts were small in both of these studies, so it's, again, hard to generalize. There's very little data assessing fracture risk in childhood onset growth hormone deficiency. So right now, really insufficient evidence to say that there's increased risk of fracture or increased bone fragility in children with childhood onset growth hormone deficiency. Okay. So as far as the role that growth hormone plays in the cardiovascular system, we know that most data available on the effects of growth hormone in the cardiovascular system are taken from retrospective studies of adult patients who have hypopituitarism. Because of that, the effects are multifold. So in addition to direct effects of growth hormone and IGF-1, there might be impacts as well from other pituitary hormone deficiencies. But overall, what we find is that in the myocardium, you have decreased left ventricular wall thickness and a decreased left ventricular mass index with a variable effect on the ejection fraction being reported. There is increased intimal medial thickness in the setting of growth hormone deficiency. We also see decreased fibrinolysis and early atherosclerosis. Growth hormone deficiency is a pro-inflammatory state, which is thought to be due to a number of factors, including increased homocysteine, an increase in PAP-A, and a decrease in tissue plasminogen activator. But the effects of growth hormone therapy on cardiovascular risk need further study. There has been data to show that growth hormone therapy often ameliorates the changes that are seen, but the extent to which there's a reduction oftentimes varies between studies. Some studies will report no change with growth hormone therapies. Others will report significant, not necessarily statistically significant, but measurable differences in all of these different factors. But there's no studies really looking at mortality reduction after growth hormone therapy compared to people who have not been treated with growth. As far as growth hormone deficiency in lipids, we know that growth hormone deficiency is associated with suboptimal lipolysis, increased visceral fat, and growth hormone also plays a role in lipoprotein metabolism. The typical pattern that we see as far as dyslipidemia is concerned is an increase in total cholesterol, LDL, and triglycerides. HDL levels are oftentimes also decreased in adult women with growth hormone deficiency, and there's increased hepatic cholesterol accumulation and downregulation of LDL receptors. The duration and severity of growth hormone deficiency does correlate with the degree of dyslipidemia, with lipid levels being inversely related to IGF-1 levels. The pediatric studies have shown more variable results, but again, very small cohort, so pretty non-conclusive overall. Data on treatment effects are promising, but overall inadequate to assess a true benefit from growth hormone therapy. So growth hormone and glucose metabolism. We know that growth hormone has a role in the counter-regulatory cascade in hypoglycemia. In the setting of growth hormone deficiency, there's decreased glucose uptake in the skeletal muscle, decreased hepatic insulin sensitivity, increased lipolysis, leading to increase in free fatty acids. So growth hormone deficiency is an insulin-resistant state. We have increased visceral adiposity, impaired physical performance, low IGF-1 levels, all contributing. Fasting glucose levels are typically normal in the setting of growth hormone deficiency. This is thought to be because of the decrease in free fatty acids impairing gluconeogenesis. And growth hormone therapy has been shown to impair insulin sensitivity. It's thought to be sort of a compensatory hyperinsulinemia picture. The overall cardiovascular risk that's due to increased insulin resistance during treatment from growth hormone deficiency is unclear because obviously you have benefits from the standpoint of body composition and lipid metabolism. So overall unclear, as I said, for like cardiovascular risk, what, if any, role this transient increase in insulin resistance causes. So what is the childhood presentation of growth hormone deficiency? The typical classic clinical scenario is a child with short stature. Short stature is defined as a standing height SDS of less than 2.25 percentile, growth deceleration or failure. So again, a poor growth velocity, less than 25th percentile should raise concern, and delayed bone maturation. But there's certainly a wide variation in presentation depending on the time of onset of growth hormone deficiency and the degree of severity. The etiology of growth hormone deficiency in children is wide-ranging. It can be including genetic syndromes such as optic nerve hypoplasia, a number of other pituitary transcription factor genetic syndromes can occur. You can have radiation therapy-induced growth hormone deficiency, mass lesions such as craniopharyngioma, which is the most common, TBI or post-surgical pituitary injury, all potential causes of growth hormone deficiency in children at various ages. Additional clinical findings that we might see in neonates, microphallus and hypoglycemia are common. There can be increased subcutaneous fat in an immature face with prominent forehead, decreased midfacial development, truncal obesity, delayed dentition, delayed onset of puberty. The adult growth hormone deficiency is quite distinct from pediatric growth hormone deficiency. We know that there's no single measure in adults that provides the degree of sort of diagnostic certainty as does growth failure in children. But there are numerous clinical features that may present and they may be present in some individuals and may not be present in others. These include increased fat mass, truncal obesity, osteopenia, dyslipidemia, insulin resistance, glucose intolerance, altered cardiac structure and function. We talked a little bit about decreased fibrinolysis and early atherosclerosis, and there are also psychosocial and neurocognitive implications. In adults, growth hormone deficiency is most commonly due to pituitary adenomas or craniopharyngioma. These two diagnoses encompass about 65% of patients who carry this diagnosis. And then we'll talk a little bit more about treatment specifically, diagnosis of growth hormone deficiency in both children and adults. In adults, the insulin tolerance test is considered the gold standard, but we know that, of course, there's a high risk of complication that is associated with that test. So really, we have kind of a tale of two different objectives. In childhood, the overall purpose of growth hormone therapy is to achieve adult height within the genetic target range, whereas in adulthood, the goal of growth hormone therapy is to alleviate adverse metabolic effects and improve overall quality of life. So as providers, how do we straddle these differing objectives, especially during the transition from adolescence to adulthood? The dilemma is that the transition from pediatric to adult care is not as simple as just continuing growth hormone, children on their current growth hormone therapy and referring them to an adult provider. And that's for a number of reasons. So first of all, a number of children who are diagnosed with growth hormone deficiency do not have permanent or complete growth hormone deficiency. So that begs the question of, do people need to be retested? If so, who do we retest? When do we retest them and how do we do that? And then who needs to be continued on therapy if not everyone does? We also know that there's a lot of physiologic changes in growth hormone secretion that happen during late adolescence. And so that means that you can't necessarily just continue young adults on the growth promoting dose of growth hormone indefinitely. If we are going to continue them on treatment, they likely need to be dosed differently. And then what are the psychosocial implications of lifetime therapy? So though we do now have long-acting formulations of growth hormone, they're not widely approved by insurance. So for many patients, this is still a daily injection, and there's a lot of stress related to that. And growth hormone is very expensive. We all know that. So what is the cost effectiveness of treating people lifelong with growth hormone therapy? So what actually is the transition period? The transition period is arbitrarily defined as starting in late puberty and extending through full adult maturation. So until essentially complete somatic and psychological maturation has occurred, typically this is going to be about 6 to 7 years after the end of linear growth. We know that after cessation of linear growth, continued growth hormone replacement can help maintain ideal body proportions and metabolic balance, and that somatic development, including development of lean body mass and accrual of peak bone mass, is occurring for several years beyond just, the completion of linear growth. So what are the goals of the transition period? They should include reassessment of the etiology and disease-specific management, reassessment of the treatment regimen, achievement of full adult somatic development, completion of pubertal, sexual, and reproductive maturation, reduction of metabolic and cardiovascular risk, and attainment of adult psychosocial development. So retesting for growth hormone deficiency in the transition period. Why do we retest? Whom do we retest, and how? And I get to make short jokes because I'm short. Okay, so why do we retest? Well, first of all, the treatment considerations vary in children versus adults. In pediatrics, all degrees of deficiency are considered for replacement, whereas oftentimes in adults, it's really only severe growth hormone deficiency that's considered for replacement. In addition, a diagnosis of growth hormone deficiency in childhood is insufficient to conclude whether a patient is going to be growth hormone deficient for life. So we know about 20 to 90% of those diagnosed as growth hormone insufficient in childhood show a normal growth hormone response when they're retested at the end of linear growth. Is this due to a true transient deficiency with an unknown etiology? Is this because of neurosecretory dysfunction, which is essentially characterized by normal response to pharmacologic stimulus, but low spontaneous secretion of growth hormone? Or is this really just the unreliability of pharmacologic tests? We also know that there's a physiologic increase in growth hormone at puberty, but there's not really necessarily a corresponding adjustment in cutoff values. So it can be challenging to translate a test done on a child to an adult. So then, who do we retest? Really, the extent of reevaluation is going to depend on the likelihood of persistent growth hormone deficiency. The first formal guidelines for care of transition patients was actually defined by the European Society of Pediatric Endocrinology in 2005. And they were the first ones to say that the extent of reevaluation really need to be based on the likelihood of profound growth hormone deficiency persisting into adulthood. These recommendations were later echoed by the Pediatric Endocrine Society in their 2016 guidelines. And then most recently, the American Academy of Clinical Endocrinologists in 2019 also put out guidelines that sort of reiterate this idea. So who are the patients that have a high likelihood of retesting as having adult growth hormone deficiency? Children that have severe growth hormone deficiency in childhood with or without 2 to 3 additional pituitary hormone deficiencies. So these include kids that have growth hormone deficiency because of a genetic etiology, HESX mutation, PIT mutations, all of those different pituitary transcription factors. The presence of severe hypothalamic pituitary anomalies. So included in this is not necessarily people who have hypoplastic pituitaries or ectopic posterior pituitaries. That has not been shown to necessarily correlate with a diagnosis of adult growth hormone deficiency as readily as some of the other more significant a pituitary anomaly, such as absence of the pituitary stalk. Those with CNS tumors are likely to have persistent growth hormone deficiency in those who received high-dose cranial irradiation. However, it is important to note that those who have received irradiation, it's really going to be dose dependent and time dependent. So depending on how long it's been since they received irradiation and how high the dose was, it's going to sort of determine how likely they are to have growth hormone deficiency. Those with a low likelihood, such as children who have idiopathic and isolated growth hormone deficiency. I did think it was interesting that children that had idiopathic growth hormone deficiency plus or minus one additional pituitary hormone deficiency were actually oftentimes found to have a low likelihood of testing as consistent with adult growth hormone deficiency. This is just a table kind of to summarize what we already talked about. All of this to say that whether we test or not test is really going to depend on each individual's clinical scenario. So how do we reassess? Paradigm to reassess transition of patients. So the first step really should be to test IGF-1 levels. So this is just a nice graph that I found. So if you have a teenager with childhood onset growth hormone deficiency whose growth is complete, meaning their growth velocity is slow to less than 1.5 to 2 centimeters per year, or their bone age has reflected closure of the epiphyses, you're going to have a growth hormone washout period, meaning that you stop their growth hormone and wait 1 to 3 months, minimum of 1 month, to retest IGF-1 levels. In children who have a high likelihood of permanent growth hormone deficiency, you get baseline IGF-1 levels. If they're less than -2 standard deviations from the norm, that's diagnostic of persistent growth hormone deficiency, and they should be continued on growth hormone therapy. If IGF-1 levels are normal, then they should undergo provocative testing. If they have a normal result, you've excluded growth hormone deficiency. Obviously, if they have an abnormal result, then they should resume therapy with growth hormone. In children who have a low likelihood of having permanent growth hormone deficiency, again, they would, after the washout period, you would obtain an IGF-1 level. And then this paper actually recommended going ahead and doing provocative testing. If you have IGF-1 levels that are normal and provocative testing, which are normal, you've excluded growth hormone deficiency. If the results are conflicting, then you would continue to monitor with close follow-ups. And if both are abnormal, then you would proceed to growth hormone therapy. So to go in a little bit more detail, talking about the washout period, this is really done to avoid false positive results. And so we have this washout period before you do pharmacologic testing. The ideal washout period to ensure reliable testing data remains somewhat undefined, though there's been a number of different studies that have tried to kind of more specifically quantify. Ultimately, here. The PES Endo Society recommended a washout period of at least 1 month, and the GRS recommended a 1 to 3 month washout period. For patients who are at risk for multiple pituitary hormone deficiencies, it's important to note that all other axes need to be assessed and hormones repleted before you can undertake repeat testing. And again, that's to avoid false positive and false negative results. So how do we do the pharmacologic testing? The insulin tolerance test is considered the gold standard test for diagnosing adult growth hormone deficiency, but there are questions about what the cutoff should be in adolescents. So typically for adults, a growth hormone level of 3 or below would be consistent with severe growth hormone deficiency, but we know that growth hormone secretion is actually highest in adolescence during the mid to late puberty. So many feel that a cutoff value of 3 is likely too restrictive. The European Society for Pediatric Endocrinology recommends a cutoff of 5, but recent evidence shows that maybe those guidelines need to be loosened a little bit. Magni et al. Did a study, and it showed a sensitivity of 96% and a specificity of 100% using a cutoff of 6.1. So there's not really been an overwhelming consensus about what the cutoff should be for adolescents. And the PES currently recommends a cutoff of 5.6 as being diagnostic of growth hormone deficiency in the transition period. We know that there's a lot of safety concerns and contraindications as far as use of the insulin tolerance test. It's contraindicated in anyone with ischemic disease, epilepsy syndromes, or anti-epileptic medications. You typically need experienced staff. There's high risk of hypoglycemia. So it is important to have other options, and it's not really a test that we do very often in the pediatric population. I've certainly never done an insulin tolerance test. The only other test that's been truly validated in the transition period is the growth hormone releasing hormone plus arginine test, but it's only been validated in lean subjects. Fortunately, we know that growth hormone releasing hormone isn't actually available in the United States right now. There's also limitations to the test inherently. It's going to miss people who have hypothalamic growth hormone deficiency. And there's also questions again about what the appropriate cutoff should be in this test. The childhood cutoff of 19 nanograms per ml was shown to have 100% sensitivity, 97% specificity, but only a very small cohort of patients was evaluated. And so really alternatives that are able to be used as recommended by American Academy of Clinical Endocrinologists is the glucagon stimulation test. It's not formally validated, but available data is encouraging in the transition period. There are BMI-specific cutoffs for this test, so we know that individuals with increased BMI have decreased response to glucagon. And so for those who are normal, for individuals that have normal BMI or overweight and have a high pretest probability, the cutoff is recommended to be 3 micrograms per ml. Individuals who are overweight and obese, the cutoff is 1 microgram per ml. The macamorelin stimulation test can also be used. Macamorelin is an oral agonist of the ghrelin receptor, and the recommended cutoff for that is less than 2.8. The American Academy of Clinical Endocrinology specifically recommends against the use of clonidine and or L-DOPA for diagnosing growth hormone deficiency, persistent growth hormone deficiency in the transition period, because it's not validated, but also because these particular tests have shown poor sensitivity and specificity in adults. Okay. So how do we manage patients who are in the transition phase? For those whose peak growth hormone falls between 5 to 10, it's recommended that there should be ongoing follow-up and surveillance. So these are folks who don't meet criteria per se for severe adult growth hormone deficiency, but whose testing is still abnormal for what would be childhood onset growth hormone deficiency. The European Society for Pediatric Endocrinology recommends offering growth hormone therapy to all adolescents with a diagnosis of severe growth hormone deficiency. We do know that growth hormone should be restarted at a lower dose, typically 0.2 to 0.5 milligrams per day. During puberty, kids are typically receiving doses anywhere from 0.025 to 0.05 milligrams per kilo per day. So this is oftentimes a significant dose reduction for them. And I did want to note that women often require higher doses, especially if they're on oral estrogen therapy. This is due to first-pass metabolism of oral estrogen in the liver, which often results in a state of functional growth hormone resistance. So they typically need higher doses compared even to women who are on transdermal estrogen. Once therapy is restarted, you can titrate the dose of growth hormone based on IGF-1 levels and clinical response. Though the overall goal is to maintain IGF-1 levels in the normal range for age and sex-matched controls, really in the setting of adult growth hormone deficiency, the clinical response is the primary marker for dose titration. So what I read is that the likelihood of side effects, especially from fluid retention, are much higher in the setting of adult growth hormone deficiency. And so if you have someone whose IGF-1 levels are perhaps suboptimal, but clinically they're doing well and their metabolic markers are reassuring, then it's acceptable to actually maintain them at the current dose. Anyone who needs additional pituitary hormone replacement should be getting it, of course. And there's not really been a consensus reached on whether there's a safe holiday period for patients who have severe growth hormone deficiency on retesting and what implication that might have for them in terms of their long-term bone density, cardiovascular risk factors, whatnot. But I know that we certainly have a lot of adolescents who have congenital hypopituitarism who get to the point of, do I have to keep doing these shots? I don't want to keep doing these shots, but there's really no data on whether that it's safe for them to take that holiday period. Okay. Again, this is just a table regarding the differences in dosing based on age, with individuals younger than 30 years old requiring much higher doses compared to older adults. So as far as management and monitoring of therapy, there should be yearly monitoring of weight, height, BMI, waist and hip circumference. Attainment of a normal peak bone mass is a therapeutic objective. We should always remember that in teens, Z-score should be used. And then occasionally it might be important to obtain volumetric data on volumetric bone density as needed. There should be yearly monitoring of the fasting glucose, hemoglobin A1C, and lipid panel, and yearly quality of life screening should be undertaken. Once the transition period has passed, peak bone mass has been accrued, you could consider discontinuing treatment if there's no other effect on other parameters after a year. So overall, in conclusion, though the adult growth hormone deficiency syndrome is widely recognized, diagnosis of persistent growth hormone deficiency in the transition period is a complex undertaking. Our understanding of the effects of long-term growth hormone deficiency, is still evolving, and communication between adult and pediatric providers is imperative to ensure excellent care for patients in the transition phase. Okay, so happy to take any questions. Yes, Dr. Krishna.
Great.
Thank you.
So a couple of questions. One is related to the bone density,
Yes.
how the initial 6 months.
Yeah.
And then, of course, in the adults, we measure maybe every 2 years, that we measure more often than that, unless they're on treatment for osteoporosis. So in pediatrics, do you guys use bone markers?
We don't actually routinely assess bone density in those with childhood onset growth hormone deficiency unless they maybe have other risk factors. So, kids that are long-term survivors of cancer and they have a number of different risk factors, and those children will oftentimes do bone labs and, screening DEXAs. But otherwise, especially the vast majority of kids we see have isolated growth hormone deficiency. We do not do routine bone density screens for them. In diagnosis, yeah, IGF-BP3.
Children, I've seen that.
It's not as sensitive as IGF-1, but it is much more specific. So if you have a low IGF-BP3, then you're certainly a lot more concerned than if you just have a low IGF-1. It's not as nutritionally impacted either. So of course, these are proteins. So we have many children that have failure to thrive, and this question of growth hormone deficiency will come up, or just endocrinopathy in general, and people will get IGF-1 and IGF-BP3, and IGF-1 is much more easily impacted by that nutritional status. So I think it has value in that setting, and again, more specific as compared to sensitivity. Once a child has been diagnosed with growth hormone deficiency, we certainly follow IGF-1s, at least yearly, but not necessarily IGF-BP3 quite as
So
often.
It's not like we use
Like sex hormone binding globulin. No.
the opposite. Like when you think about sexes having BP3 higher, is it more sensitive than?
To be honest, pituitary gigantism is so rare. that I don't know off the top of my head. I've never seen a case of it clinically. My guess is that we would probably get them both. I think I would probably rely on IGF-1 more. And then, if you have a high degree of clinical suspicion, you're going to do the oral glucose tolerance test anyways. But I don't know if any of you guys have insight into IGF-BP3 for diagnosis of pituitary gigantism, but
We don't use it.
yeah, no, I would think more IGF-1. Yeah.
So that studies that have looked at like 30 years.
In adults,
No, from starting for pediatric, because it's only been there for 40 something. Yeah.
not like, well, I think that
How many people continue?
you guys might be able to answer that better than I am, but from what I can tell, not a lot. I mean, like I said, like for people that have the vast majority of kids that I have that have isolated growth hormone deficiency, when we go through the washout period, we recheck an IGF-1, it's normal. You have a very low degree of clinical suspicion that they have persistent growth hormone deficiency. But, those kids that do have a high pretest probability, so kids that have, history of craniopharyngioma or kids who have multiple pituitary hormone deficiencies, many of them stop growth hormone essentially right away. But I do have, sorry.
Is it known why in adults, some patients manifest some symptoms, but not others?
No, but my guess is it just depends on really the severity of their growth hormone deficiency. And I don't know, but sometimes I wonder, like in some of my kids that have multiple pituitary hormone deficiency, who struggle with adherence, for instance, they kind of already feel poorly just because they're hypogonadal and, they're kind of hypothyroid and it's like the shot is one more thing, but they don't necessarily feel all that different on it because they already feel poor at baseline. But in my more compliant patients, I see that they're the ones that are more likely to stay on growth hormone because they do feel the difference. Oh, sure. Thank you. Yeah, they do kind of feel that difference a little bit more, but that's just my kind of clinical experience. But I feel like the vast majority of them are pretty ready to stop. So a question here says, I teach endocrinology to seniors and graduate students. Every year, students ask me about using growth hormone supplements for bodybuilding. What brief response would you give them? Don't do it. Don't do it. So I guess what I would say is that, treating giving someone growth hormone because they're growth hormone deficient is not the same as giving someone who is growth hormone sufficient growth hormone. Anytime that you take a medication or a supplement, it's always going to be risk versus benefit, right? So if you're truly deficient, then the potential, benefits of therapy are going to outweigh any potential risks. But if you're not truly growth hormone deficient, then you're much more likely to, get your IGF-1 levels and whatnot into super physiologic ranges, and you're going to have increased risk of side effects with relatively limited benefits. So, and also like no endocrinologist is probably going to prescribe that to you. So where are you getting this growth hormone? Is it really growth hormone? What else is mixed in with that growth hormone? Don't do it. That's what I would say. So that's basically what I tell them. They find it online. Yes, don't get growth hormone online. That's my recommendation. Anyone else? All right. Well, thank you guys so much.